Greetings, everyone. Welcome to another review from Nurture Oncology. Although our first three reviews focused on oncology specifically, today we are taking a slight different approach and reviewing a surgical article, which is a must read for all the aspiring surgeons and the clinicians present in this group and watching this review. So, this is basically routine sterile graft and instrument change at the time of abdominal wound closure to prevent surgical site infection, ChEETAh, a pragmatic cluster randomized trial in 7 low-income and middle-income countries. This was published in Lancet, and it's a really great article. I hope you like it. As you all know, surgical site infection is most common complication of surgery around the world and disproportionately affects patients in low-income and middle-income countries. Therefore, it is the highest research priorities in research in a global co-prioritization exercise. So the national institutes of national importance like WHO, CDC, and National Institute of Clinical Excellence do not recommend any routine change of gloves and instruments before wound closure owing to a lack of evidence. In support of this statement, the authors presented with some brief review, where they, after having mesh terms in these bases, they did not find any assets recommendations about routine change of gloves and instruments, citing a weak evidence base. Though they received several articles, which are listed here in this paragraph, upon this protocol, but those trials were either had a moderate or high risk of bias, and overall quality of evidence was low. Therefore, added value of this study was that their aim was to conduct a large and rigorously conducted, transparently reported trial, with a diverse and representative range of patients. And they especially focused on middle income and low income countries because incidence of surgical site infections is high in these countries specifically. And the high adherence rate with the intervention they provided showed that this routine change of gloves and instruments is actually possible and deliverable around the world. So, implications we'll see after the results. Coming to the methodology, so this was an international multi-center trial, cluster randomized control trial, and this was done to evaluate routine change of gloves and the use of separate sterile instruments at the time of wound closure to reduce SSI rates in patients undergoing surgery with an abdominal incision. The protocol was already established and is cited in reference number 13. You can go to the reference number 13 and check it out. This was a cluster randomized trial design, and these countries were chosen. Any hospital, the cluster was at the level of hospital. So any hospital providing non-cesarean elective or emergency abdominal surgery in these countries were eligible to participate. And there were no restrictions imposed to hospital type, size, or surgical volumes. And patients undergoing emergency or elective abdominal surgery for any indication with an intraoperative finding of clean, contaminated, or dirty operation with at least one abdominal incision of 5 centimeter or greater included, as fully described in Appendix P9. You can check this in the appendix. Now, here, clean contaminant surgery was excluded as infection rates are low in that. Further, patients undergoing cesarean section were also excluded because large trials of intervention in cesarean section are already present. But general abdominal surgery, cohorts are not reported as such, or not there with low risk of bias. Then there was no individual patient consent taken, as this was done at hospital level. The operation was done at hospital level, and only verbal, written, or fingerprint patient consent was obtained for the purpose of 30-day outcome assessment only. Coming to randomization and masking, so they randomly allocated the hospitals to routine change of gloves and instruments, that is the intervention group, or to the current hospital practice, that is the control group. And a minimum of 4 hospitals were required per country. So masking was not possible because uh like all the people, like they were allocating this intervention at a hospital level. So all the people performing that surgery knew about the intervention because the surgeons, the assisting staff were required to change their gloves, and the scrubbing team, the nurse team was also required to change the instruments. So masking was not possible, although the patient was masked. And they did to like prevent like bias. Because of this this limitation, they did additional analysis to eliminate the bias. Further, coming to the procedure, there were two key components. One is the gloves, and the operating surgeon, assisting surgeons, and scrub staff all changed the sterile gloves or outer gloves if they were double gloved. And instruments, a sterile set of instruments was used for abdominal wall closure, including a needle holder, forceps, and scissors. And for example, they said either there could be two sets of instruments, one used before the wound closure, and or like another one, a totally new set, or they could like the scrub team could prepare another set of instruments before the starting of operation. So the protocol stipulated that change of gloves and instruments should take place after completion of the abdominal component of the operation, but before handling the wound edges to facilitate closure. And in this pragmatic trial, other SSI reduction measures were at the discretion of the surgeon, like skin preparation solution, bondage protector, and other measures. Outcomes, coming to the outcomes. So they, like, all the primary analysis were done on the basis of intention to treat principle, that is a um and intention to treat principle, that is participants from all hospitals were analyzed in the groups to which the hospitals were located. And they also tried to include missing data, uh, like missing data due to patients who were lost to follow-up or who died before the primary outcome assessment was recorded as ESR, the discharge assessment. The primary outcome was SSI up to 30 days after surgery, and outcome assessors were trained to assess each patient's wound status. Like they could either do it via face to face or via telephone, and they had a like series of predefined questions mapped to these CDC criteria. And the secondary outcomes were recorded at 30 days post-operatively, unless otherwise stated, and comprised um, post-operative mortality, SSI at discharge from hospital, unexpected readmission into hospital for a wound-related problem, unexpected reoperation for a wound-related problem, return to normal activities, and length of hospital stay. So as this intervention is in use in all around the world with a high level of safety, they did not anticipate any adverse events, and they didn't collect any specific data related to it. Coming to the statistical analysis, so they plotted an alluvial graph, which we can see here. We'll come to that later. And they they like, this is the basic flow chart where we can see that they randomly assigned there were a total of 81 hospitals assigned in 7 countries, and 42 hospitals were allocated to the current practice, and 39 participants were allocated to routine change. Out of these 42, one hospital was excluded, and the rest of the 41 hospitals were included in intention to treat analysis for primary outcome. Uh, in the like in the intervention group, no, like, zero hospitals were excluded, and all the 39 hospitals were included for analysis. Coming to the results, so these are the baseline characteristics of all the patients. There were no like significant differences between the like control and the intervention group, as you can see, uh, in terms of age and gender, like diabetic status, smoking status. Then here we can see the different types of surgeries. Follow up, we can see that like most of the patients were followed by a telephone, and then followed by like in-person hospital asking method. Then time of surgery, these are like this is basically the descriptive analysis part. The main outcome which we can see is the SSI rate was approximately like 18.9% in the current practice group and 16.1% in the intervention group. And the p value is less than 0.005, which states that these results are statistically significant. Further, there was no evidence to suggest heterogeneity of effect across any of the pre-specified subgroup analysis. So, the result was like a protective result. Risk ratio is also less than 1. We can say that this intervention is actually beneficial in reduction of surgical site infection. Further, they stated that there was an absolute reduction, although not significant, in the risk of SSI at hospital discharge and the risk of reoperation within 30 days, favoring glove and instrument change, which suggests that reduction in the risk of SSI might lead to improvement in other less common consequences of wound infections. So, here, with reference to this, the absolute reduction is of about 13%, which was compared with the trial control group. That means a reduction of 1 in every 8 SSIs. So, this is a really good outcome. And there are certain strengths to this study. Coming to the first strength, we can like this, as this is a multi-central study. The like it is a head there is like heterogeneous settings and surgery showing a beneficial effect of this simple practice in diverse and real world settings. Further, the design of the study was assessed to reduce bias and like have a detailed mitigation plan with active monitoring and report these measures carefully and transparently, which they clearly achieved. And the third strength was that they achieved all the data prior to their projected time and target during the SARS COVID-2 pandemic. Further, this study also had some weaknesses. They've also listed some weaknesses. There were like minor imbalances in patient characteristics across groups, which were inevitable in a cluster design, particularly with such a broad and heterogeneous hospital group, which is understandable. All they did covariate, like they did patient level covariables, and to minimize this cluster randomization, and they also did like additional statistics with several sensitivity analysis to remove that bias. Further, this trial was unmasked, as we saw earlier, that intervention engaged members across surgical and perioperative team were all aware. This was but the thing is that the outcome assessors who like assess the outcomes were not asked to make a binary assessment about SSI, reducing the subjectivity and risk of detection bias. Further, the third limitation was that there were some clusters that included a lower number of patients than expected due to low volume or site opening towards the end of the trial. And for the fourth limitation was that they were not able to collect data around the practice of single versus double gloving. Double gloving being common in some low middle income countries, owing to higher rates of blood-borne viral infections in the general population. So the results of this trial, they demonstrably justify a change in global practice within operation theaters. Now the cost of routine change of gloves and instruments are low but not negligible, especially when patients have to pay them out of pocket. Although like nowadays most of the surgeries are shifting to minimally invasive surgeries, they've also stated that still in these countries especially, abdominal incisions are commonly required and SSI remain high in well-resourced settings too. This is stated in reference number 1. Further, like the further research targets and following ChEETAH include understanding the role of changing drapes and the effect of reusable drapes counts and hands-on infection outcomes. So they have successfully achieved a positive impact on this intervention, and further they would go ahead of the role of changing drapes and like effect of reusable drapes, which might also have a positive impact on reducing surgical site infections. I hope you like this. Thank you, everyone.